I apologize, it looks like we have only one screen, which may ruin the effect, because when there's two, if you cross your eyes right and focus on the third one in the middle, you get a 3D effect. It's really, really great. So the topic tonight is marijuana. I don't know why, for some reason, I can't resist puns on the topic of marijuana, so I subtitled it The Highs and Lows. Sorry about that. It'll be a blast, I promise, and you can be blunt with me if need be. I've been thrown out of better joints than this, and there's always greener grass on the other side. Okay, that's enough of that. So what I'd like to cover tonight is sort of a primer on cannabis products. Now, I realize there are probably people in the room who know a lot more about cannabis products than I do, but I frequently heard from some of my healthcare colleagues after Alaska legalized, oh, I had no idea that's what we were talking about. And I've heard that from a number of people. So I just want people to be aware of kind of what is out there and what we'll likely be seeing in Alaska as well. Talk a little bit of science about cannabinoid pharmacology, and then talk about the sort of like any drug, talk about benefits and risks. And benefits are primarily related to medical uses, and then spend some time on what we know about the health risks from marijuana, and then close talking a little bit about health system and public health effects of legalization. So, little mind picture game here. So when I say the word marijuana, what do you picture?
The leaves.
The leaves, okay.
Relaxation.
Relaxation, okay. Abuse. What product do you usually think of? I see somebody doing an air toke there, so thinking of a joint, and I think that's what a lot of people think of is a joint or maybe a water pipe, a bong, as they say, a blunt, which is basically a cigar, oftentimes has tobacco and marijuana rolled up together. But that is so 1960s. So let's sort of fast forward a little bit and talk about the broader range. First of all, when we're talking about retail marijuana, we are talking about something other than what you buy in the parking lot. We're talking about marketing, we're talking about branding. Up at the top there, you've got Barry White brand. I don't know if that makes you have a really deep voice or not, but every store I've ever been in has an Obama Kush, and I have no idea how Obama got linked to marijuana. And then on the bottom, actually flavored marijuana, which is kind of interesting given that the FDA has gone towards banning flavored tobacco products except for menthol, since that's already on the market. Speaking of the parking lot, the retail stores may be very different than what you may be picturing if you haven't been in a retail store. I haven't seen one like this in Alaska yet, but this is in Denver. Looks kind of like the Apple Genius Bar, but this is a cannabis store. You can get vaping solutions. You can get, of course, branding. Snoop Dogg has one that somehow it's supposed to be vapable with herbal product in it. I don't know how that works exactly. But you can get vaping solutions, and I'll show a little more about how vaping of THC oils affects the pharmacology of the cannabinoids. Probably the big thing, though, that is new is the edibles, not just brownies. Edibles are generally made by extracting cannabis oil from the product, basically hash oil, and then infusing it into the product. Sometimes it's called butter. I think people who don't use marijuana have a misperception that somehow leaves are ground up in the brownies. It doesn't work that way. It's an extract that is used in the baking process. Now, in Colorado, when they first legalized, there was also products that were sort of standard products and then sprayed with THC. That is no longer legal in Colorado and has never been legal here. But the variety of products is really huge. I think basically if you can eat it, you can buy it with THC in it. So on the bottom there, chocolates are very popular, and given the oily fat content, it seems to make sense. There's some mints. You've got cannabis-infused spicy chili lime almonds. You can get and treat the munchies at the same time. Across the middle, slips. These dissolve on the tongue. And then some elixirs, some teas. Lots of beverages. Here's a soft drink that Shiva has two brands, sativa and indica. Now, Cannabis sativa is the genus and species of cannabis that we usually think of when we picture marijuana. Somebody was saying earlier they pictured a leaf. So the long kind of spiky leaf, that's Cannabis sativa. And it's a tropical plant, grows best if it's got a 12-hour light-dark cycle. So to grow sativa brands generally requires blackout shades in northern environments in order to give the plant a 12-hour dark cycle. Cannabis indica is more of a temperate climate cannabis plant, a little shorter, a little stubbier. There's actually also a cannabis that grows in the Arctic. It doesn't have a lot of THC, so it's not very popular, and I won't say anything more about that. I bring this up because there's a lot of marketing about sativa versus indica. Everybody loves variety. And oftentimes products are sold as sativa is energizing, it's uplifting, it's a head buzz. Sativa is relaxing, it's a body buzz. Pharmacologists have looked at the different products and really had a hard time distinguishing them. Certainly users sometimes swear there's a difference. I'm not saying one way or the other, but just be aware it's part of marketing. The Dixie elixirs there on the right-hand side shows some other soda products that are available in Colorado. If the munchies are causing a little bit of weight problem, don't worry, there's a sugar-free cannabis drink. Now, I have to say, I love this tagline. Whatever. That's the best tagline in all of marketing, I think. You can get your Keurig cup with cannabis-infused, for making cannabis-infused coffee. There's sprays across the middle of the slide there that basically go in and are absorbed through the oral mucosa. Over on the far side there, Body Buzz is a topical. Now, at this store, and I should acknowledge Uncle Josh's was very kind to let me come in and take pictures and ask a lot of questions because I've had a steep learning curve on cannabis products for the past 3 years. And so I was looking at it and I didn't see a lot on the label about how it was being transferred through the skin. So I said, is this really absorbed through the skin? And the sales girl said, no, sir, but it makes a great personal lubricant. And so I'm looking at her thinking, okay, if this is going to be a battle to see who can embarrass who more, there was a voice in my head saying, you're going to lose. So I just sort of moved on from that topic. But then my eyes went down, and there were tear-out articles there. And first of all, it struck me as funny because there were tear-out articles from Cosmo. And those of you in medicine may remember when medical meetings oftentimes had tear-outs from the medical journals. So I thought, well, that's kind of funny. But they were sort of all the same. There were like 3 different ones. They all had a headshot of a young woman, usually with bare shoulders and a look on her face like she just accidentally stepped on something really sharp on the floor. And the headlines were things like 15-minute orgasm. And I thought, okay, I'm glad I didn't get into it with this gal. But the reason I tell that story is there's a lot of marketing out there and a lot of claims, and there's not necessarily a lot of evidence for all the claims. So just let the buyer beware. So moving into the pharmacology then, there are dozens of cannabinoids, the active ingredients. The highest potency is in the flowers of the female plant, which you see in the middle there of the upper picture. The trichomes are little hairs that are on the buds that contain resins, and that has the highest concentration of all. And so the close-up there of the trichome shows you can actually see the little droplets of resin. Most of the cannabinoids bind to two specific receptors in the brain, sort of unimaginatively entitled the CB1 and the CB2. The cannabinoid that usually is of greatest interest is delta-9 tetrahydrocannabinol, which we most all know as THC, and that's the main active ingredient with psychoactive effects. Now, I mentioned on here something called 11-hydroxy-THC because as we talk about edibles, the THC that's in edibles is absorbed through the GI tract and goes to the liver and then is converted to 11-hydroxy-THC. And it's a little different than the delta-9 THC in that it may actually have more powerful effects on the brain, and it actually does have a greater tendency to be able to cross from the blood into the brain at higher concentrations. So it's an important thing to keep in mind as we begin to think about edibles and how they act. The other one that you'll hear on the news quite a bit is cannabidiol, or CBD. Probably has little or no psychotropic effect, but it probably does have some therapeutic effects in certain types of seizure disorders. There are really a whole slew of other cannabinoids. There's a whole class called terpenes that may have effects, but I'm not a chemist and we don't have 3 days to go through all of this. So what happens when you use? These are some slides that show the blood THC concentrations after 10 or 25 milligram doses. The color coding shows different ways of using. So it's a little bit out of order, but the blue line is vaping solutions. The purple line is smoking, and the oral is after ingestion. And I think the take-homes here is, first of all, you can get higher blood levels of THC from vaping solutions than smoking. But also, particularly at the 25 milligrams, you can see the delay in the peak with edibles. Now, that doesn't necessarily mean, you'll notice it's lower, but that doesn't mean that the effect is less because THC is converted to 11-hydroxy-THC, which is not what they were testing for, and may actually have a more powerful effect. I don't know if people have ever read the editorial in the New York Times by Maureen Dowd. We sort of joke sometimes about the Maureen Dowd effect. She had come out from New York to the Denver area to do some investigative journalism, visited one of the chocolatiers who gave her a bar of chocolate. This was before they had any of the labeling requirements that they have in Colorado now. So she went back to the hotel room and she wrote about this later. Thought, well, I smoked a little pot in college. I'll try this. You know, good investigative journalism. So she had that little piece and waited about 20 minutes and didn't feel anything, and ate another piece and waited about 20 minutes. Well, you know how the story goes, I can tell. And then, this stuff doesn't work, and ate the rest of the chocolate bar, being someone who liked chocolate, and then describes what began to happen about a half hour after that, and then sort of an 8-hour ride of holding on to the bed, praying that the room would stop spinning around. So it can be a very unpleasant experience if you don't know how the edibles will work. 25 milligrams, of course, is a pretty big dose, particularly for someone who doesn't use very often. And some of the products that were available in Colorado at the time had even higher doses than that. So how does it affect other organs than the brain? THC does tend to elevate the heart rate. The y-axis here is just the heart rate, looking at the different modes of use, vaping, smoking, and eating, same color scheme. And you can see again that pretty much immediately the heart rate goes up after smoking or vaping. It's more delayed with the edibles. So this slide's sort of complicated, but I think it's really important because this is a question I get a lot, and that this relates to secondhand smoke exposure. So the two graphs on the top, the y-axis is basically a measure of whether or not you feel high or not. The bottom two graphs are blood THC levels. The two lines, the squares, are unventilated room. The triangles are ventilated room. And what you have in the left-hand side is the smokers. The right-hand side is non-smokers who are in the room. So what you can see is that certainly people who were exposed to marijuana smoke, even if they weren't using it, felt like they were getting a buzz. And actually, they did get a little bump in the THC levels. And Dr. Vandry, who conducted this experiment, also documented that it is enough to be able to turn a urine test positive for at least a brief period of time. So an important take-home there, particularly if tomorrow you're going to get a drug test for a new job and you know there's a drug-free work site, you may not want to hang out in a room full of people smoking marijuana. Now, this is experimental conditions, as I'll show you. So the left-hand side is the unventilated room. It's pretty dense with smoke. The right-hand side is ventilated. And I have no idea why that hand is coming into the picture. This was the unventilated room. Maybe that had something to do with it. So let's talk about medical marijuana a bit. So cannabis has been around for centuries and used both recreationally and medicinally. It actually was on the U.S. Pharmacopoeia until 1942 when it was removed, and that was part of the process of making it illegal in the U.S. I think I'd summarize everything as there's a lot of claims, but the good data are really sparse. There are a few areas where I think there's pretty firm data now, and I'll get into those details in a minute. But it's a tough question to answer for a number of reasons. First of all, I've tried to simplify the pharmacology as much as possible, but herbal marijuana has lots of different compounds in it. And studies of individual cannabinoids, such as CBD, cannot necessarily be extrapolated to use of herbal marijuana or complete any strain extract that's put into an edible. Probably the biggest challenge is it's a Schedule I drug. So legally, the Drug Enforcement Administration or agency puts marijuana in the same category as heroin and LSD and everything else. And I think that will change because the definition of a federal Schedule I drug is no accepted medical use and high risk for abuse. I think that's probably an overstatement, particularly when you compare marijuana to alcohol and think, well, alcohol is not even considered a controlled substance. You may have seen in the paper some federal legislation that's been proposed, the Compassionate Access, Research Expansion, and Respect States Act, the CARERS Act. The Senate version of the bill is co-sponsored by Lisa Murkowski, and the House side is co-sponsored by Don Young. So a lot of Alaskan input in there. One of the challenges, I think, for us in healthcare is that because of the Schedule I status and some of the challenges in getting good data, we're left with indications oftentimes defined by state legislatures. And it's all defined in Alaska Statute Title 17. It lists what are some of the indications to get a medical marijuana card. Some of them, as I'll show in a minute, have some evidence. Glaucoma is terrible. The intraocular, the pressure lowering effect of cannabis on the eye only lasts about 30 minutes. So you would have to be stoned all the time to really get a good benefit from glaucoma. It's my only chronic disease. I've never considered marijuana. I use what my ophthalmologist recommends. Another problem is just the whole process. Then every state comes up with their own list. And it's usually defined by who the advocates are. Some of the advocacy is very impassioned. You would think they were arguing in favor of access to oxygen as strongly as the arguments are made. The Illinois really caught my eye because there's things like the nail patellar syndrome that, I've been in medicine over 30 years now. I've never heard of it till I saw it on the Illinois indication list. In Alaska, we've had a medical marijuana program since 1996 for a couple of specific debilitating conditions that you saw on the earlier slide. Now, I always think it's important to point out that Alaska is fairly unique among the states with regards to marijuana. Because of the Raven decision in 1975, marijuana has really been quasi-legal in this state for over 40 years. So when I'm talking to friends and health officials from states that have recently legalized, I say, well, you know, Alaska's probably not a very good comparison because marijuana really has not been that big a deal here for a long time. It's gone through various cycles. I say quasi-legal because the legislature has gotten involved and decriminalized, and then it was recriminalized, and then we had medical. But our medical program has never defined where you get the marijuana because on the basis of the Raven doctrine, it was interpreted by the Alaska Supreme Court that the right to privacy under the Alaska Constitution includes the right to grow and possess small amounts of marijuana for personal use. So another way that we are very different from the other states is we've never had marijuana dispensaries. It's kind of been, if you will, a don't ask, don't tell, but because building on the Raven doctrine, it's assumed that if you need it, you can get it. For grins, when I was last seeing patients, which has been about 3 years now, I had a patient with fairly advanced liver disease from hepatitis C that was really bothered by muscle spasms and got relief from using marijuana. And so I just thought I'd ask, do you have any trouble getting access to it? And he looked at me kind of sympathetically and said, no, doc, no trouble at all. Just, okay. I learned a lot from I do miss patient care because they always taught me so much. Public use was prohibited under the medical marijuana laws. It does require a permit, and to get a permit, you have to have a statement from a provider that, quote, according to law, is in a bona fide physician-patient relationship. Now, I'm not sure exactly what that is. I think most people know that there was a guy that used to come in and check into a suite at the Baranoff in Juneau and, you know, set up his weekly or his monthly marijuana clinic. I think he was coming in from Seattle, but he had a Alaska medical license. We do not collect hardly any data for people getting medical marijuana cards. Again, we hold privacy as very almost sacrosanct in Alaska, but I can tell you about 75% of all the patients are seeing one doctor. So it's clear that some physicians prescribe a lot of marijuana and others not so many. Just my personal experiences, I don't know that I've ever actually recommended it, but sort of hidden somewhere in that bio, I was an infectious diseases fellow just before antiretrovirals came out. So I was attending on a ward of 40 patients with advanced HIV at Grady Hospital in Atlanta, and we had a lot of patients with advanced AIDS cachexia, and just anecdotally it seemed like it did help with bringing the appetite back. So we had, because we also had a lot of tuberculosis and just had this new ward built, we had negative pressure rooms, and so all I had to do was write an order in the chart, patient may smoke in room. It was sort of known that there were patients that needed marijuana in the building. Cops kind of didn't look at the deals that went on down on Butler Street, which is not named after me. It's the street that Grady Hospital was on. And it just kind of happened. It wasn't actually till years later I realized that was actually a felony to let all that happen. So I'm glad the cops sort of looked the other way for that. I do think of one patient in particular, though, that put on about 10 pounds after he started using marijuana. Anecdote, and my caution is always, the plural of anecdote is not data. So there's a reason why we do very careful studies of anything that is being recommended as a medicine. The fee is $25. It's good for a year. You can renew it for $20. Cards from other states are not valid in Alaska. The number of patients that actually are registered stayed really low for a number of years until 2012 when the Cole memo came out. They legalized in Colorado and Washington, and all of a sudden we had about 2,000 people with medical marijuana cards. Now that's about tenfold per capita lower than what it was in Colorado, because Colorado actually had a different tax rate if you had a medical marijuana card. They also collected a lot more data in Colorado than we did, and so I was amazed to see how many thousands of 20 to 25-year-olds had chronic pain syndrome in Colorado, but I won't. I'm editorializing, so I'll avoid that. The benefits, though, included just legally affirmative defense. Affirmative defense is basically like when the cop pulls you over and says, "Where's the fire?" If you say, "My house is burning down, I got to get home," that's an affirmative defense, and they may even lead you home. If you say, "What do you mean? I wasn't going fast," that's lacking an affirmative defense, and you probably just got a ticket. By the way, I'm really bad at legal advice. It does allow caregivers to be able to use the card. This actually is addressing a problem they had in Colorado because somebody could say they were a caregiver and they realized they were caregivers with over 600 people they were taking care of. It was a pretty robust business plan. So kind of to summarize, what do we know about the benefits? What can benefit from treatment with cannabis? The National Academy of Medicine, which until very recently was known as the Institute of Medicine, did a fairly exhaustive review and although a fairly quick review, but one that was in depth with a number of people who have spent their lives researching cannabis, and concluded that there is conclusive or substantial evidence that cannabis or cannabinoids are effective for the treatment of chronic pain in adults, chemotherapy-induced nausea and vomiting, and muscle spasticity specifically associated with multiple sclerosis. Everything else they looked at, which was a very long list, they concluded there was moderate, limited, or no evidence for other indications. Now, the big caveat in there is the Schedule 1. So there are many conditions which have not been researched or are being researched now. For instance, the VA is involved in a trial using cannabis for treatment of PTSD. And as some of the neuropharmacologists have explained it to me, there's reasons to think that might be a benefit. We just don't have the clinical benefit or the clinical data to confirm that yet. So, I mean, the bottom line is stay tuned. I think there will be more data, and hopefully the regulatory mechanisms will change as well. I did want to say a little more about chronic pain syndrome because of the issues that we have with opioids. Now, this slide's a little complicated, but let me just explain what it is. It's an ecological analysis comparing the states that have medical marijuana laws with those that don't, and the rates of prescription for Medicaid beneficiaries for different classes of drugs. And you can see the prescriptions for pain medications, the further to the left you go, the bigger difference there is between the medical marijuana legal and the other states. The further to the left you go, the more difference there is. And pain medications really stand out. The others, not so much. They also looked at things for which there are no claims for marijuana, like treating blood clots or influenza or other bacterial infections, and found no difference at all. There's a lot of different lines of evidence that do support the concept that marijuana can be useful in treating chronic pain syndromes and can actually reduce the use of opioids. Let's talk specifically about cannabinoids for epilepsy. That's not a brand new idea. There's some older writings about using different types of hemp extracts to treat epilepsy before we had much of anything else. In the brain, of course, we have cannabinoid receptors that They're probably not there because our primate ancestors smoked a lot of grass. They're there because our brains also make cannabinoid type substances for various reasons, and those are called the endocannabinoids. The endocannabinoid system is strongly activated during seizures. So the concept is if you combine those receptors with an exogenous cannabinoid, perhaps you can reduce the frequency of seizures. There is a product that is under review by the FDA right now called Epidiolex, made by GW Pharmaceuticals. I have no financial relations with them. It is a plant-derived concentrate of a strain that has primarily CBD and very little THC. In some of the open-label trials, there was some evidence of a placebo effect. One that was done in Colorado, they actually found that the parents reported more benefit if they had actually moved to Colorado to get this treatment. So a little bit like the concept of you're going to use the gym if you pay for it, and if you get it for free, you're not. But in blinded placebo-controlled trials that really are the most rigorous type, it has been shown that young adults and children with Dravet syndrome, which is a severe, difficult to control seizure disorder, the ones who got CBD had about half the median number of seizures per month, whereas in the placebo arm, there was very little difference at all. Using other measures, it didn't quite achieve statistical significance, but the proportion of patients that had a 50% reduction in seizures was much higher among the CBD group, and there were 5% in the CBD group that actually became completely seizure-free, whereas none in the placebo group does. So, I mean, my take-home from this is it's not a miracle drug, but it looks like, particularly for some of these seizure disorders that really we don't have a lot of other good options right now, it can be beneficial. There were adverse events, so it wasn't like it was Kool-Aid. So the people who received the CBD, again, not knowing if they were getting CBD or placebo, were more likely to have loss of appetite, diarrhea and vomiting, fatigue, sleepiness, fever, and abnormal liver functions. Let's talk about toxicity. I remember in the lead up to ballot measure 2, a common line was no one has ever died of marijuana poisoning. And to my knowledge, that is true. People who I think are a little crueler than I am have done the lab experiments to see what would be the dose of intravenously infused THC that would kill a monkey. And it's about 130 milligrams per kilogram, which for a 70-kilogram human being translates into about 9 grams. And if you remember the earlier slide showing the physiologic effects of THC, we were looking at 10 milligram and 25 milligram doses. So this would be a huge dose. The WHO did some calculations on what does that mean in terms of the ratio for what in medicine we call the lethal to therapeutic ratio, basically the amount that can kill you compared to the amount that has an effect. And it's at least 10,000 for THC, assuming a 10 milligram dose, which is many, many-fold higher than what it would be for ethanol or for heroin. So let's talk a little more broadly about adverse health events. So we've talked about medical uses, potential benefits. Let's talk about the downside. Short-term, impaired short-term memory. There have been studies, it's not uncommon that you'll hear students say, well, I study better when I'm high. And that's kind of a perception, but at least when it's tested, you don't retain as well when you study when you're high. Can be a loss of coordination, which the biggest issue there is then when we're talking about getting behind the wheel of a car and driving. And in experimental conditions, THC levels that are fairly low in the 2 to 5 range have been associated with impaired driving skills, particularly in infrequent users. This was also one of the leading adverse effects that the National Academy of Medicine identified as being of concern. and particularly when alcohol and THC are used together, the effects seem to be more than just additive. And at least the theory is that you try to compensate when you have alcohol or THC on board, but the compensatory mechanisms are each compromised by the other drug. And maybe that's reflected also in the adverse effect of altered judgment. There was a study where they asked, can I drive safely under the influence of marijuana? Then they asked about under the influence of alcohol. And some of the respondents actually were high when they took the survey, and if they were high at the time, they were more likely to say, yeah, I can drive, no problem. At higher doses is where you get into more trouble and more likelihood of interaction with the healthcare system. Agitation can occur at higher doses. There can be paradoxical anxiety, even psychosis. Like most things that are a little over the top, like reefer madness, there's a grain of truth in there. Some people have more problems than others, particularly at higher doses of THC. One of the big issues that was seen in Colorado with edibles, particularly among children, with a really high dose, sometimes the agitation can be followed by sedation. And there's been at least 2 instances of kids who've been in the ICU, actually on ventilators, because it looked like their breathing was slowing. That's the kind of thing we think of in terms of opioid overdose, and all they could do was really support these kids till they cleared the THC, because there's no specific antidote. There's nothing like naloxone for THC overdose. Longer term effects, it's a lot more unclear. The thing that probably stands out and has got the best evidence base is a toker's cough is a real thing. People who smoke a lot of marijuana for a long time can tend to have a productive cough. When you stop, it goes away. I don't know what Willie Nelson sounds like when he wakes up in the morning, but I wouldn't be surprised if he doesn't have a cough. There is an association. In general, people who have used marijuana are more likely to use other drugs. But I really want to point out that I see you're skeptical, so I'm going to play to that. In a stress association, I don't think the science supports the concept of a gateway drug, that there's some sort of biologic mechanism that leads to that. I think it probably reflects more just the fact that people who experiment with one drug might be more likely to experiment with others. Comparing this to like opioids, where we have a very specific receptor and a very high likelihood of addiction. If we look at prescription opioids and the likelihood of using heroin, it's many fold higher for use of heroin than marijuana. So it's sort of one of those associations that their association is not causation. Psychiatric symptoms, this is, again, that reefer madness thing. It is documented. There's enough data that at least the National Academy of Medicine concluded that it is possible to unmask schizophrenia. There's probably a genetic predisposition to that. It's also pretty darn uncommon. Probably the biggest concern is dependence. And I'll use the term addiction. I don't know if that's appropriate or not when we're talking about marijuana. But it's thought to be about 1 in 10 people will have some problem with an overuse type behavior down the road. That is about the same as the proportion of people who drink alcohol, who have problems with alcohol. The risk is higher, again, kind of like alcohol, with earlier age of initiation, and also people who are daily users tend to have a more difficult time backing off or reducing, or may get into problems that where the use of the substance becomes more important than other things in their life, such as continuing their job or the relationships in their life. There is a cannabis withdrawal syndrome with craving, irritability, sleep difficulties, anxiety, and depression. One thing that's kind of different, and you may hear about, the medical term is cannabis hyperemesis syndrome, also known as greening out. It's a paradoxical effect. I was mentioning earlier with AIDS cachexia, marijuana seemed to stimulate the appetite and help people gain weight. It's a paradoxical effect because it's severe nausea and vomiting, also abdominal pain. There's actually been people who've been taken to the operating room because of suspicion of appendicitis, and actually they were just greening out. We don't know how this works. It does seem to happen more often in people from families with a history of migraine headaches. The treatment is kind of weird. Hot baths seem to make it resolve, and oftentimes people who suffer from this know that and will oftentimes self-treat themselves. It's also resistant to the drugs that we usually give to treat severe vomiting. A drug called haloperidol, which is an antipsychotic, seems to have some effect, but when I talk to my colleagues in the emergency department, they mostly say they put the person in a wheelchair and roll them in the shower room and give them a good hot shower, and they start feeling a lot better. And also make sure they have fluids, because the biggest risk would be dehydration. It goes away. Sometimes it takes 48 hours, which is a long time to really vomit a lot, but it can be treated. And it goes away if you just stop using cannabis. So it isn't a malignant syndrome, but something that requires avoidance of cannabis. Big question is safety in pregnancy. And there's more questions than answers at this point in time. THC does cross the placenta. Based on animal models, it's about 10% of the maternal levels show up in the fetal bloodstream, although it may be higher with more repeated exposures. THC is kind of funny like that because it's fat soluble. So trying to compare what we know about alcohol doesn't play out very well because of that fat solubility that THC has. Part of the concern is getting back again to the endocannabinoid system. Some of that parts of the brain are present very, very early in development, and the CB1 and CB2 receptors are fully developed by about the second trimester. So as I said earlier, those endocannabinoids are probably there for a reason, and it's thought that they're essential to normal brain development based on some animal studies. And at least one animal study has suggested that if you overwhelm the endocannabinoids with exogenous cannabinoids, you can disrupt normal brain development. And what I found really troubling was increase the susceptibility to effects of ethanol. This is the kind of thing that really keeps me up at night, because I don't think this is strong enough evidence for health policy, but it's very concerning. And I think, I'm not sure when we'll have answers to this exactly, but it really does, to me, justify our recommendation that if you're pregnant, it's best not to use THC products. The use in pregnancy has been associated with, again, I emphasize associated with, because this doesn't prove causation, lower birth weight, maternal anemia, greater risk of neonatal ICU admission, and at least in a few studies, impaired impulse control, visual memory, and attention during school years. THC also appears in breast milk. At least some study from humans suggests it's fairly low concentration. I will sort of put in a side note here. I've heard of women actually being discharged from breastfeeding support programs because they said they were using marijuana. I would not advise that. I think it's better to breastfeed and also to encourage breastfeeding, even in someone who is using marijuana products. Again, that's my opinion. Roughly half of marijuana users report that they continue to use during pregnancy. The lightest gray line here shows the proportion of women in Alaska who report using marijuana during pregnancy. That pretty much doubled between 2002 and 2011, and while it's not on the slide, it seems to have kind of leveled out since then. Nationally, there is kind of an interesting study looking at THC concentrations in newborn meconium. Meconium is that first bowel movement, which if you've seen it, it's dark green, it's really sticky stuff. I used to hate it if you got it on your shirt accidentally because it never washed out. Nationally, about 10% of all specimens at both 2012 and 2014 were positive in all the states that participated. But in 2014 in Colorado, there were higher concentrations of THC in the meconium. So while overall use may not have, or the proportion of the population that was pregnant that was using may not have changed, it does suggest that the frequency of use had become more, had increased in a state with legal retail sales. As a result, some of the medical organizations have put out recommendations. The American College of Obstetrics and Gynecology says there's enough evidence to suggest that marijuana, contrary to popular perception, is not a harmless drug, especially during pregnancy. American Medical Association in 2015 recommended pregnancy warnings for labels for cannabis products. As far as we have not done that in Alaska, at least not yet. As far as I know, Oregon is the only state that has done that. I'm using may, I'm using could. Is this just weasel words? Well, I'm trying to be as scientifically accurate as possible, because while there are some things we can say conclusively, there's a lot that we can't. One is the health effects may not really manifest for years. And yeah, marijuana is nothing new. It's been around for years. It was very popular in the 60s and 70s, and I don't think that popularity ever really waned. But there have been changes in the products that are out there. In the epidemiological studies, there certainly is confounding, because until very recently, most people who smoked marijuana also smoked tobacco. And the National Academy of Medicine concluded that they really couldn't say one way or the other that marijuana smoking increased the risk of cancer. In fact, if anything, they thought that the evidence suggests that it is much lower than tobacco smoking. Alcohol use is also fairly common among cannabis users, or has been, as well as has other drug use. There's also confounding from social determinants, because until fairly recently, marijuana use was more common among people of lower educational attainment, lower income. People may be aware of the big cohort study of kids in New Zealand that concluded there were all kinds of school problems that occurred. And I don't doubt that the kids that were exposed had more problems down the road, but it has been questioned whether or not the researchers really controlled for some of these other factors that we know are associated with poor school performance, such as low income or an unstable household environment. Most of the studies on pregnancy don't really assess when exposure and gestation occurs. We know from alcohol that there's a critical period very early in gestation when the risks are greatest. We also have the new products. That's why I started that way. So edibles, vaping, dabbing, these are things that are much more prevalent now than in the past. Statistically, controlling for multiple comparisons could be a problem. But probably the big thing is this ain't your grandma's marijuana, that there's increase in THC concentrations in combustible marijuana, primarily because of the way the horticultural techniques that have been used to make a more powerful product. That impact on use, this is something that one of my colleagues in Colorado sent me. And the broken lines show the prevalence of use of cannabis products. The blue is adults, the green is adults age 18 to 25. The solid lines are Colorado. And it does appear, at least based on these data, that the use of cannabis products has increased in Colorado since their retail legalization in 2012. The other health effect that we often have sort of paid attention to in Colorado has been the inadvertent ingestions. There were increases in admissions to Colorado Children's Hospital from kids who ate what they thought looked like a gummy bear. So in closing, I want to sort of offer this model and the way I've approached the fact that marijuana is legal in this state. Just for full disclosure, I'll say I did vote against ballot measure 2. I can't say I felt very passionate about it, but coming into this job, I felt like I had the responsibility to execute the mandate of the people and to be able to regulate marijuana in a way that people could use it responsibly and be able to also mitigate any adverse health effects. So the model, the way conceptually I approach it is everything's a graph for me, I'm sorry, it's just the way I'm wired. So harm on the y-axis, regulation on the x-axis. No regulation is the pure commercial model. The other end is the prohibition model, sort of the extreme end of regulation. And at least in my mind, I think the goal is to hit between the two where the harm can be the least and that we can also have as little regulation as possible. And that's what I like to think of as the public health sweet spot. So that we can avoid some of the things that came up in Colorado, the 100 milligram gummy bear. You remember the effects of a 25 milligram dose. Now, I don't know about you, but when I'm getting the gummy bear out, I don't pull out the knife and say, would you like white meat or dark? That is a big dose. And it was really kind of fun to read the online reviews. I mean, some people just thought they were great. There were several that just said, these are very strong. But I don't think that went well for them. And this has actually been something we've, particularly in Alaska, I think we've had a reasonable relationship with the retailers. And I think they know that there's really no advantage of that first experience being extremely negative. We also worked with the public health authorities in Washington and Colorado to explore that question of what's a reasonable dose. The 10 milligrams was driven primarily out of their legislatures. As we talked to health officials and health experts, they said we still see people who really are not happy and come into the emergency department after our first use at 10 milligrams. So both Alaska and Oregon went with 5 milligrams. That is what we would recommend as a serving size for someone who is using for the first time. I think most people who are regular users sort of learn how to self-titrate, and so that's the route we've gone down. Also, Colorado initially had no laws on packaging. They do now. We were able to learn from their mistakes. I don't know about you, but I'm always in a hurry, and I probably wouldn't read very carefully, and I could eat a Buddha finger before I knew what it was. And that was actually an issue that came up during testimony in 2015, that some of the trucking companies, they weren't concerned that their drivers were going to intentionally use a cannabis product. There was concern that they could unintentionally use something and get behind the wheel. So these kind of things are not legal. Case law was beginning to drive it already because some of the manufacturers of the other products were beginning to sue the manufacturers of these products. Labeling, my goodness, does anybody read what is on that upper one? It's an awful lot. I think we learn as we go. Colorado used to have this marijuana enforcement division, had to be on everything. They've changed to this branding as a way just to market as a THC product. Oregon went a little more international, using something that had no wording or letters at all. One advantage of what they did in Colorado is you can actually brand it right onto a cookie. There's a lot of things you can write with chocolate, and anything written in chocolate is okay by me. So this is, I think, part of the learning process as we go forward. So I hope I've presented a fairly science-based and as well as balanced view of marijuana in Alaska. I see it is 8 o'clock, but I'd really like it if we could take a few minutes for questions. I think the memory card on the video is probably about shot, but be happy to take questions. Yes, sir.
In your research, did you just stay within the states that have already legalized marijuana, or have you expanded your research, for example, to the Netherlands, where that's been going, they have their bars, pot like. And then, so all your discussion
Yeah. So first of all, I appreciate the compliment that as if I'm doing some sort of really nice systematic research. that was very kind. That's probably a little bit of an overstatement. It's basically I try to read whatever I can get my hands on and talk to anybody I can. I think maybe the better model than some of the European countries have different venues which are decriminalized. Portugal has basically decriminalized everything, but that's different from legalization. And Uruguay is the country that probably is where I would look to a model that is closest to what we've done in the 8 states in the US. And they legalized for a very specific reason. The marijuana black market was tied to a lot of drug violence. And so they have legalized and actually created a retail outlets around the country that are run by the government. So the government has actually stepped in and is the dealer there now, if you will.
Mike, I'm sorry, I'm miscommunicating. It's the effect of what it does to the body, especially in children. That's what I was trying to get, your research and the effect on the body.
Yeah, well, I think the issue of, are you talking about specifically inadvertent childhood exposure?
Well, I mean, just the body alone, because the Netherlands have been, and you just mentioned other countries that have been doing it for a long time. So, I mean, you're showing us the pros and cons of the use of marijuana. And here you have these countries that have been doing it forever. Seems like.
Yeah, well, actually, Uruguay only legalized in 2014. The coffee shops, though, in the Netherlands, I mean, they've been around. You know, the impact that's had on usage, it doesn't mean that the entire pregnant population of the Netherlands uses marijuana and we just compare them to France. So I don't think the numbers have quite created maybe the database that you're getting at. And also the evolution of the products is sort of a global thing as well. I mean, the old Cheech and Chong joke about it was all oregano. There's some truth to that, and what is available now is much more pure. In terms of you know, the engagement, I don't consider myself a global cannabis expert, but in terms of like the NAM committee, it certainly included input from European experts as well. So, yes, ma'am.
In Alaska, can children be given marijuana and medical marijuana? And if so, who controls how much they're getting? What kind of regulations are there to protect the child?
Yeah, great question. It's about children using medical marijuana. So the short answer is yes, a child can get a medical marijuana card. It requires parental consent, and it also requires the recommendation of a physician. The numbers have been extremely small. Even when we had 2,000 medical card holders, I think there were only 7 or 8 that were under age 18. So it was a small number.
But who controls what's happening to them? Some pharmacists?
Yeah, and that's actually a even broader question and a even better question, if you will, because what the part of the reason I think what we're doing in Alaska can be a good thing is just what you're saying. As a provider who may be approached by a patient, should I use marijuana? Well, I'm used to using substances with a known dosage. I'm used to using substances that have, you know, some kind of safety testing. So, you know, there's advantages to legal regulation, including the fact that you could actually have a product that has a characterized amount of THC or CBD or whatever, also be tested for pesticides or fungi or some of the other things that there really may not be nearly as much quality control for products that were available through the black market. So I think that's part of the challenge of how we have done it in the past, is there's sort of the assumption that you can get it somewhere, but you know, there was no guarantee that it actually contained what the person selling it said was in it. Yeah, that was sort of the look on my face as I learned more about
Is
this.
a doctor supposed to, is there any regulation that says a doctor is supposed to supervise this?
Nope,
So you just get it, whatever you want to give your child, you just guess.
that's right. And that's part of the problem.
What about this fellow's question here about the children in the Netherlands?
The Netherlands, I mean, these are recreational outlets, the coffee shops. I'm not even sure children are allowed to go in there. So, yes, ma'am.
Can you restate, or maybe I didn't hear, what you said about, I believe it was the CBD topical applications? Did you say something about the research isn't in on whether that's helpful or not?
Well, I never mentioned CBD topicals at all, so I'm not sure.
Whatever the topical is.
Well, the topicals are usually an extract. It's an oil. You know, how much is actually absorbed into the skin kind of depends on what some of the carriers are that are mixed into it. The point of the story is that if it's applied to mucous membranes, it is absorbed more readily because you don't have the epidermis to be able for it to be delivered through.
So if you were looking at muscle spasm-y kinds of things, it wouldn't necessarily.
Yeah, and I have not seen clinical data on assessing topical creams for muscle spasms. Doesn't mean it's not there, but I haven't seen it. Gunnar.
Thank you so much for your presentation. This is really a lot of excellent information. So are you prepared to talk about some of the neurodevelopmental effects in adolescents and some of the research that's out there from THC exposure?
Yeah, so sort of in broad strokes, I mentioned in passing that the risk of having problems with a cannabis use disorder seemed to be higher with earlier onset of use. And that seems to jive with what we know about brain development, that really the reason you know everything when you're 14 is you've probably got the most neurons you'll have in your entire life at that point in time. And then there's a period of about a decade that's sometimes called neural pruning, where the brain kind of readjusts a bit. And it's part of the reason why 14-year-olds are incredibly athletic and powerful, but they may not still get beat by their 35-year-old dad because coordination and a little more learning how to get to the hoop is different. Part of the issue with that process during neural pruning is it does appear to be a period of time where the risk of addictive behavior is higher. And that's true not just for cannabis, but also for alcohol and also for tobacco. And that neural pruning doesn't end on average until about age 25. So it's fairly far into adulthood before that risk completely disappears. I want to be really clear, it's not the same in every person. There's nothing magic that happens on your 25th birthday and suddenly there's no more risk. But it is a process. So I think it does justify the prohibitions on use of cannabis under age 21 in this state. You could make a state, certainly make a case for an even higher age, but 21 is kind of handy because it aligns with our laws for alcohol as well. Some states have done that for tobacco now. We haven't. Yes, sir.
As far as medical uses, like what I hear a lot from my peers, especially people my age, young adults, is this is kind of going back to the syndrome of withdrawal. A lot of people my age use it to treat anxiety, social anxiety, depression, those sorts of things. A lot of things that are associated with college, and what would you kind of recommend for people who are self-medicating for that, or what? I don't know, just a general statement on the affairs of young adults using it a lot to treat anxiety, especially.
Yeah, so the question about using it to treat anxiety. Anxiety is tough because, the class of medications that have the most data are the benzodiazepines, which have sort of their own sets of problems as well. However, at least a benzo is oftentimes more characterized where you know what you're using. At this point, I would have to say I don't think we have enough clinical data to really answer that question well. I've never heard of a study, say, doing a head-to-head comparison of benzos and cannabis. That sort of gets back to that issue of trying to change some of the regulatory barriers, because that's a really interesting question and potentially could be very beneficial, because we know benzos have their own risk of dependency as well as respiratory depression if they're mixed with some other drugs, particularly opioids. So, thank you. Do we have one more?
Last question.
Okay.
Okay.
I'll answer any question for someone with purple hair. So.
You mentioned in the risks of THC and marijuana use during pregnancy that there was increased risk of ethanol susceptibility in the infants. What is that?
Yes, so this is based on animal data, and this is, I sort of called that out because even though it's a little more getting into the basic science, it's the kind of thing that really worries me. So what it would suggest is,
Could you repeat the question?
oh, I'm sorry, thank you. So it was going back to that question, I was referring to some animal data that suggests that cannabis exposure may increase the risk from ethanol exposure during early pregnancy. And ethanol exposure can lead to fetal alcohol syndrome. So what at least this animal data would suggest is that using both alcohol and cannabis during early pregnancy would be extremely risky. You know, again, it's animal data, and it's always a little troubling when you try to extrapolate from the lab animal to human beings, and even more so when you try to extrapolate that to what's good health policy for all of us as a population. But I think I tend to agree with the American College of Obstetrics and Gynecology. I think the data are concerning enough that it's valid to really recommend against marijuana use during pregnancy. So, thank you.